Intentionally paralyzing a human being requires manipulating the body's electrochemical signals. You have to intercept the command to move before it ever reaches the muscle. This interception happens at the neuromuscular junction. An action potential arrives, opening voltage-gated channels. Calcium rushes in, triggering exocytosis. Vesicles fuse, dumping thousands of acetylcholine molecules into the cleft. The enzyme acetylcholinesterase instantly intercepts, hydrolyzing half the ACH before it crosses. The remaining byproducts, specifically choline, are immediately pulled back into the presynaptic terminal to synthesize the next batch of acetylcholine. The neuromuscular junction operates as a highly regulated, high-volume chemical relay. Sustaining movement, or safely suppressing it, requires balancing this constant cycle of release and destruction. Paralytics target the nicotinic acetylcholine receptor. A mature receptor has 5 subunits: 2 alpha, 1 beta, 1 delta, and 1 epsilon. 2 acetylcholine molecules bind the alpha subunits, changing the receptor's shape. A central channel opens, flooding the cell with sodium ions. This local depolarization triggers adjacent voltage-gated sodium channels, sending a signal deep into the muscle to release calcium from the sarcoplasmic reticulum. That internal calcium release forces actin and myosin protein filaments to slide past one another and lock, creating a physical muscle contraction. This receptor population reacts drastically to trauma. Severe denervation injuries, like large burns, spinal cord transections, or strokes, trigger a massive structural change known as upregulation. In response to the injury, the muscle rapidly sprouts hundreds of immature fetal receptors. These swap the normal epsilon subunit for a gamma subunit. They stay open longer and are exquisitely sensitive to depolarizing drugs, creating a high risk of lethal hyperkalemia. Conversely, conditions with a constant, prolonged presence of agonists, like myasthenia gravis, cause downregulation. The receptors remain physically present on the membrane, but they become completely deactivated. A patient's underlying physiology dictates if a paralytic secures the airway or triggers a catastrophic reaction. In the operating room, clinicians have traditionally relied on physical cues to determine if a patient is ready for extubation, checking for a sustained 5-second head tilt or a firm jaw clench on a tongue blade. Qualitative visual assessments of muscle function are notoriously inaccurate. The clinical gold standard requires objective quantitative evaluation, specifically mechanomyography. We measure the depth of paralysis using the train of 4, or TOF, sequence. A nerve stimulator delivers 4 electrical pulses at a frequency of 2 Hz, allowing us to measure the resulting twitches. Seeing 4 equal twitches visually mimics full recovery, but up to 70% of receptors could still be blocked. To accurately gauge the drug's effect, we measure fade, the progressive drop in twitch amplitude during the sequence. Fade happens because non-depolarizing agents block presynaptic receptors on the nerve terminal. This blocks the positive feedback loop that normally sustains high-volume acetylcholine release during recitative stimulation. This dynamic distinguishes the block type. A depolarizing phase 1 block shows 0 fade and no post-tetanic potentiation. A non-depolarizing block clearly exhibits both. Estimating the strength of a microscopic chemical blockade with the naked eye is a gamble. Safely confirming recovery requires objective mathematical proof. Succinylcholine is the only clinically used depolarizing neuromuscular blocking agent. Structurally, it is extremely simple, just 2 acetylcholine molecules linked together. Because of this structure, it acts as a prolonged agonist. It forces the receptor channel open, causing an initial, visible muscle fasciculation. This sustained depolarization locks the voltage-gated sodium channels in an inactive state, resulting in a phase 1 block that completely paralyzes the muscle. Succinylcholine has an incredibly short half-life. It is rapidly hydrolyzed by butyrylcholinesterase directly in the blood plasma, meaning only about 10% of the administered dose survives long enough to reach the neuromuscular junction. This metabolic pathway introduces a major genetic variable. Clinicians use the Debucane test to measure the quality of a patient's plasma cholinesterase. A normal score is 70 to 80. A score of 20 to 30 indicates a homozygous atypical variant, meaning a standard dose could paralyze the patient for up to 8 hours. Because it mimics acetylcholine systemically, succinylcholine carries severe side effects. It stimulates cardiac muscarinic receptors, causing sinus bradycardia, raises intraocular and intracranial pressure, and is a known trigger for malignant hyperthermia. Administering succinylcholine to pediatric patients carries a severe risk of triggering massive rhabdomyolysis and lethal hyperkalemia from undiagnosed muscular dystrophies. It is strictly contraindicated in children outside of emergency intubations. While succinylcholine offers unmatched speed for securing an airway, its reliance on a variable genetic enzyme and violent physiological effects make it a high-risk tool. Non-depolarizing neuromuscular blocking relaxants act as purely competitive antagonists. They bind to the alpha subunits, physically blocking acetylcholine from attaching without ever activating the channel. With these agents, potency is inversely related to the speed of onset. The more potent the drug, the longer it takes to achieve full paralysis. We divide these drugs into two chemical classes. The aminosteroids, rocuronium, vecuronium, and pancuronium, are highly dependent on organ function for elimination. Rocuronium clears through the liver and kidneys, while pancuronium relies almost entirely on renal function. The second class consists of the benzyl isoquinolines, which include atracurium and cis-atracurium. Cis-atracurium is highly utilized in critical care because it utilizes Hofmann elimination. Hofmann elimination is an entirely organ-independent degradation process. The drug spontaneously breaks down in the plasma, driven purely by normal physiological pH and body temperature. Atracurium also undergoes Hofmann elimination, but with notable drawbacks. It produces a higher volume of lidonosine, a central nervous system stimulant, and actively triggers histamine release, which can cause significant drops in blood pressure. Selecting a non-depolarizing agent requires matching the drug's specific metabolic exit strategy to the patient's individual organ health. Neuromuscular blocking agents do not operate in a vacuum. The presence of inhalational volatile anesthetics directly potentiates their effects, prolonging both the duration of the block and the recovery time. Other medications rapidly compound the blockade. Magnesium sulfate deepens paralysis by inhibiting presynaptic calcium channels, while antibiotics like aminoglycosides depress postsynaptic receptor sensitivity. The patient's physical state alters the timeline. Hypothermia severely limits enzymatic activity and delays drug clearance, heavily prolonging paralysis. Conversely, patients on chronic anticonvulsant therapy develop a distinct resistance to non-depolarizing agents. Their recovery accelerates, necessitating significantly higher doses to maintain intubating conditions. There is also the persistent risk of anaphylaxis. Neuromuscular blocking agents are responsible for the highest incidence of anesthesia-related allergic reactions, with rocuronium and succinylcholine driving the majority of cases. Maintaining an even plane of paralysis requires vigilance. Every temperature drop and concurrent prescription actively shifts the pharmacological balance. The final phase of the procedure is actively reversing the non-depolarizing blockade. Traditionally, clinicians use cholinesterase inhibitors like neostigmine. Neostigmine does not interact with the paralytic. Instead, it forms a covalent bond directly with acetylcholinesterase. By disabling the enzyme that clears the synaptic cleft, natural acetylcholine accumulates, eventually outnumbering and outcompeting the paralytic molecules for the receptors. This indirect method has a strict sealing effect. Once the patient's acetylcholine esterase is completely inhibited, giving larger doses of neostigmine provides absolutely zero additional reversal. Profound blocks cannot be overcome this way. Flooding the entire nervous system with acetylcholine creates an intense autonomic surge, causing profound bradycardia, severe bronchoconstriction, and heavy salivation. To prevent this, pharmacological pairing is mandatory. Neostigmine must be co-administered with an anticholinergic agent like glycopyrrolate to block these dangerous muscarinic side effects. Classic reversal is an indirect mathematical equation. You overwhelm the neuromuscular junction with natural neurotransmitters while simultaneously medicating the patient to fight off their own autonomic backlash. The introduction of sugammadex offered an entirely new method of reversal. It acts as a selective relaxin-finding agent, bypassing the biology of a neuromuscular junction. Sugammadex operates physically. It is a modified gamma-cyclodextrin ring that circulates in the blood plasma, actively swallowing free steroidal pyrrolidid molecules and locking them securely inside its central cavity in a 1-to-1 ratio. This chart shows its absolute selectivity. It possesses a massive affinity for rocuronium and vecuronium, but has zero effect on succinylcholine or the benzyl isoquinolines. At 16 milligrams per kilogram, it immediately reverses a profound rocuronium block, faster than the spontaneous recovery of succinylcholine. The encapsulated complex is biologically inactive, but it relies heavily on renal clearance, making it unsafe for patients with severe renal failure. Its binding properties also neutralize oral contraceptives. Rapid reversal is a powerful tool, but it does not replace mechanical skill. In a cannot intubate, cannot ventilate scenario, securing the airway remains the absolute priority.
The behavior of these drugs, whether triggering a phase 1 depolarization or establishing a competitive blockade, is entirely dictated by the physical structure of the receptors. Choosing between an aminosteroid and a drug utilizing Hoffman elimination requires analyzing the specific capability of the patient's liver and kidneys. Safely engineering and reversing paralysis requires abandoning visual assumptions. It demands a rigorous understanding of receptor physics, a precise evaluation of organ function, and an absolute reliance on objective, quantitative data.